So can I ask Dr. Agnieszka NOWOSIELSKA, macular hole treatment in retinitis pigmentosa?
Good afternoon, everyone, and it's great to be here, and it's an honor and a pleasure to have this presentation. Today, I would like to say a few words about macular hole surgery in retinitis pigmentosa, and because this is very rare disorder, this kind of surgery will not be your everyday practice probably, but I hope you find it very interesting. We know what retinitis pigmentosa is. This is inherited disorder, and the patient experienced the loss of vision and the loss of peripheral visual field. However, what is very important in retinitis pigmentosa, those eyes develop also macular pathologies, and the prevalence is around 80% of them. They have some sort of pathology. The most prevalent is epiretinal membrane, but vitreomacular traction is also quite frequent, lamellar holes, but the major study that was published in 2019 did not find even one single case of macular holes. So macular holes are really, really rare in those patients. Here is the surgery which I performed more than 10 years ago. Because at that time the reverted flap technique was not popular, was not presented yet, and I myself was not smart enough to invent it because, as you can see with the flap that I create, I could easily do the inverted flap, but I had no idea I could do that. But what I wanted to point here is the yellowish tissue that you could see in a moment. This tissue is like retinal proliferation seen in pseudoholes or lamellar holes, which is quite resembling what we can see in those different disorders. Here is the OCT of the patient, and although the hole was quite small, you can appreciate the morphology is totally different than the idiopathic macular hole. You can see the epiretinal tissue, which is pointed with the red arrow. And what is quite important, this patient waited 3 years to be operated on because actually nobody was eager to do the surgery because of obvious reason. This is the second surgery that I did recently, last year actually, and you can see here that I'm trying to peel the ILM, which is difficult. The ILM is not stained well. It comes in pieces, so actually creating the flap would be very difficult. This retina is very, very thin, so actually on a table you could have the feeling that when you touch the ILM, you touch the sclera, which is underneath. And in the end, I just ended up with just clinical peeling because no flap was able to be created. This is the OCT of the patient, and again, the morphology of the macular hole is different than in idiopathic macular hole. The hole was closed, but you can see that architecture of the retina is different, much different than from the healthy retina. So is it worth operating on? Yes, it is worth operating on because the central field is the only field that those patients have. And you need to understand and remember that with a little vision that they have, this is actually the world they don't have anymore. They don't have a spare eye to be implanted as a third one. The ILM peeling will be difficult, the staining will be difficult, the retina is very thin, and you need to be prepared to change the scenario of your operation while you proceed. But those patients are very thankful, so if you ever come across such a patient, please try your best. Thank you so much.
Thank you.